Good evening, everyone, and thank you for joining us today. We are excited to have you all here for another wonderful patient webinar, Clear Vision Ahead, the latest advances in cataract surgery technology. My name is Gabriel Macias, Business Development Manager for Harvard Eye Associates. It is my pleasure to introduce our presenter for the evening, Dr. Ashraf Ahmad, Cornea, Cataract, and Refractive Surgery Specialist. Dr. Ahmad is a board-certified, fellowship-trained ophthalmologist who specializes in cornea, cataract, and refractive surgery. He is highly skilled in corneal transplant, ocular surface reconstruction, cataract surgery, and other complex anterior segment procedures. He also has a special interest in LASIK and PRK. Dr. Ahmad completed his fellowship training in cornea and refractive surgery at the University of California, Irvine, Gavin Herbert Eye Institute, and is a member of the American Academy of Ophthalmology and the Orange County Society of Ophthalmology. Dr. Ahmad, thank you so much for being here to host tonight's patient webinar.
Thank you so much, Gabe. It's a pleasure to be here. And thank you to all the attendees for taking the time from your evening to join us. I always like giving these webinars because it gives us a lot more time to go into in-depth conversations on cataract surgery. What are the technologies that are available to you? What are the lens options there? And so we're going to take a deep dive tonight, and I hope that you're able to take away some pearls moving forward. And so for the agenda tonight, one, we're going to talk about what is a cataract, kind of get into the basics of the anatomy there. Then we're going to talk about what the cataract surgery entails. Then we'll dive into the lens choices and options that are available to you. And we'll end with laser-assisted cataract surgery and aura. So briefly, just a little bit about myself. I'm a cataract, cornea, and refractive surgeon here in Orange County at Harvard Eye. I did most of my training in Ohio, did my medical school at Northeast Ohio Medical University, my internship at the Cleveland Clinic, then did my residency at Case Western Reserve, and then completed my training at UC Irvine in a fellowship there, cornea and refractive surgery. And so cataract surgery is one of my passions. I love being able to combine surgical precision, technology, and really fine tune what I'm able to deliver to patients. And I also like to kind of figure out what the patient is wanting to get out of cataract surgery and really try to deliver that as best as we can. Now, what is a cataract? So we have sort of the basic anatomy photos here. On the left, that's normal anatomy where you have a clear lens. We all have a clear lens that we're born with, and that sits behind the colored part of the eye, the iris. And over time, that lens becomes cloudy, and that's essentially what we call a cataract. And it's a very gradual process that basically involves protein building up within that lens, and that's what ultimately causes the lens to cloud. Typically, it's an age-related process, so a lot of patients will start to develop cataracts in their late 40s, 50s, and then cataract surgery shortly thereafter in their 60s and 70s. But there are other risk factors as well that can lead to cataract development. One, we talked about aging being the most common, but diabetes can also speed up or expedite cataracts. Steroid use for those patients who are on oral steroids like prednisone or are using inhaled steroids for COPD or asthma, that's also a risk factor as well for the progression of cataracts. If you get a lot of sun exposure, if you're in, for example, California, that sun exposure can definitely speed up the rate at which cataract progresses. Smoking and trauma are also known risk factors that can influence that speed as well. Now, what are the symptoms of cataract? So oftentimes patients will come in and sort of they're not clear on what symptoms are related to cataract surgery, but here's a few of those. And blurred vision is very common, trouble driving at night, trouble seeing road signs, a lot of glare and halo, all of that can be attributed to cataracts. Double vision, less frequent, but is a possibility with cataracts as well. And then fading of colors or loss of clarity of vision can also be a sign of cataract. Now, what does cataract surgery entail? So the basics of cataract surgery is that it's an outpatient procedure. You're not under general anesthetic. It's just twilight sedation. So you get a little bit of medication in the IV to keep you comfortable. The surgery itself is 10 to 15 minutes per eye, and we typically space out the eyes 1 to 2 weeks apart. And that's sort of the cataract surgery in a nutshell there. As far as the surgical steps, and just to kind of give you a high level view of that, the first part is we make small incisions in the cornea, and there's two small incisions. One is 1 millimeter, the other is 2.4 millimeters. So very, very tiny incisions. And then we go into the eye and we use phacoemulsification, which is just a fancy word for ultrasound, to break up that cataract. Once that cataract is broken up into small pieces, we remove it and ultimately implant a brand new lens in its place. So you can see here the schematic of the ultrasound breaking up the cataract and then the new lens or the new IOL intraocular lens going in place. Now, as far as recovery, we ask for 2 weeks, no heavy lifting, no bending, no straining. There's going to be a couple of drops that you do afterwards for about a month, and that will vary depending on your provider and your insurance as well. So some patients who have coverage for Dextenza, for example, will that Dextenza implant, we do it at the time of surgery, that replaces the steroids. So those patients are often only on one drop once a day for about 3 to 4 weeks. But the majority of patients typically have a steroid eye drop and an NSAID for about 1 month. An NSAID is basically an Advil drop for the eye. Now, as far as intraocular lens choices, so once that cataract is removed, we have to replace it with a brand new lens. And that brand new lens ultimately determines what you're able to see with and without correction. And there's a lot of options out there. I will preface this discussion by saying that there really is no perfect lens that gives you the full range of vision and maximum quality of vision. So the technology is fantastic, but it's not going to be able to replace what you had, when you were 20 or 30 or 40 even. So each lens that we're going to discuss has its pros, has its cons. So you just kind of have to weigh the risks and benefits of each and decide ultimately what your goals are and what you'd like to get out of cataract surgery. And that ultimately kind of guides our decision making there. So the beauty about cataract surgery is that you have plenty of options. So right now it's a great time to be a patient because the technology is at its best. And so there are a lot of lenses out there, and depending on your personal goals and your personal needs, we can meet those and sort of align what the technology can offer with what you're looking to get out of surgery. Now, I kind of like to think about it as step one and step two. Step one, you're choosing your lens, and we're going to go through a series of lenses here that are the most common lenses and kind of talk about their pros and cons. Once you've decided on the lens, then you're going to pick your technique, which is step two. So, do you want to do manual surgery or do you want to do laser-assisted surgery? And we'll get into the differences between the two later on in this presentation. Now, just a quick word about astigmatism correction. When we do cataract surgery, it does give us the opportunity to correct your astigmatism. And astigmatism basically is when your cornea is shaped more like a football than a basketball, and it can cause blurred vision. We can either correct your astigmatism at the time of surgery, where we implant a special lens to correct for it, or you just wear glasses or contacts afterwards to correct the residual astigmatism. So reasons why people would choose to correct their astigmatism at the time of surgery, one is it offers better quality of vision. Two, it's going to reduce the need for glasses after surgery. And three, it's going to improve the overall best corrected vision. So a lot of times patients see it as an opportunity to be able to correct the astigmatism and to really minimize the need for glasses after the fact. Now, I always like to reference this chart here when I'm speaking to my patients regarding cataract surgery, and this is the range of vision chart. So I kind of divide it into three ranges. One is near vision, which is reading menus, looking at your cell phone, reading a book. Two is the intermediate vision, which is about computer length away, arm's length away, or tablet. And then distance is going to be your driving, television, cycling, golfing, outdoor activities type of distances. And so keep this in mind as we go through the lens options. So first up, we have the basic monofocal lens. So this is the lens that's traditionally covered by insurance. And this lens is set for one focal point, typically distance, and it's going to give you great quality vision. But we typically say that you're going to need to wear glasses for all ranges of vision. So distance, intermediate, and near. So afterwards, you're probably going to have to wear a progressive lens or a bifocal lens. And that's because there's no astigmatism correction built in. So this is a fantastic option for anybody who doesn't mind wearing glasses and is looking to get really good quality vision. Now, we're going to go through a series of these profiles just so that we can compare them at the end. So with the basic lens profile, if you have astigmatism, you're going to need to wear glasses for all ranges of vision. If you don't have astigmatism, which is a very, very rare subset of patients, then you'll have good distance vision, but then you'll still need to wear reading glasses for up close work. Next up, we have the toric lens, and the toric lens is a lens that's designed to correct your astigmatism. So it's set for one focal point, and toric just means astigmatism correcting lens. So this lens is going to offer you less dependence on glasses and really fantastic vision. So for my patients who have a lot of astigmatism and are looking to get the best quality vision, this is sort of my go-to option for that specific patient. And when we look at the toric lens profile, you can see here that patient who gets a toric lens is going to have great distance vision without need for glasses. And then you're going to have to wear reading glasses for near work and intermediate work, and very good quality vision as well. Next up, we have the extended depth of focus IOL. And so this lens is going to give you two focal points, meaning distance and intermediate should be clear without glasses. And then you'll need a pair of reading glasses for fine print. So astigmatism correction is available if needed in this specific lens. And this lens is going to give you great quality vision. There is a little bit of a chance of glare and halos, but it's very minimal. And so for somebody who's looking to get independent of glasses, but wants to minimize that sort of the glare and halos that can sometimes happen with multifocal lens, this is a great option. So again, you're going to get distance and intermediate vision here and reading glasses for really fine print. So who's the right candidate? So not everybody is a candidate for all of these lenses. So when we're looking at the Vivity lens or this extended depth of focus lens, we're looking at somebody who desires more range of vision, but wants to minimize the glare and halos, is willing to wear reading glasses for fine print, and may have some mild ocular pathology. And that'll come into play when we talk about the multifocal lenses. So there's a subset of lenses that are multifocals we'll get to next. In order to qualify for that lens, you really should have a pristine eye, meaning no retinal pathology, no glaucoma. Your ocular surface should be fairly well. But with this extended depth of field lens, it's a little bit more forgiving. So if you have mild ocular pathology, you may still be a candidate for this lens. Now, the multifocal lens is the lens that's going to give you the full range of vision. So you're going to get distance, intermediate, and near vision with minimal need for glasses. There is astigmatism correction built in if you need it. But with this lens, so those are the advantages, but there is a disadvantage, and some of our patients will have glare and halos. Typically, if you do experience glare and halos, it's at night when you're looking at headlights. And most of the time, within 6 months to a year, they diminish with time. So a lot of the patients who end up getting multifocal IOLs will say that the glare and halos that they're experiencing often have reduced or improved over time. And so again, this lens is going to give you distance vision, intermediate vision, and near vision, but keep in mind that side effect of mild glare and halos, which typically get better with time. Now, who's the right candidate for that multifocal lens? It's going to be somebody who wants the full range of vision, but more importantly, is willing to tolerate some imperfections in the vision, so some glare and halos there. And from a physician standpoint, we really want to see no ocular pathology. We want to see a very healthy retina, a very healthy optic nerve, no glaucoma when we're deciding to implant this lens in a patient. Now, this is sort of a depiction of what those glare and halos can look like. So the first photo on the left, you can see 1 month after surgery with a trifocal implant. You can see around the tail lights, they're not as sharp and not as distinct, but 6 months after surgery, you can see that simulation shows that they're a little bit more sharp, a little bit more discernible as well. In comparison, the last photo on the right is a monofocal lens implanted after 6 months. So this is your basic standard lens that's covered by insurance. You can see the distance vision is pretty crisp, but it's difficult to see the details when you're looking up close at, for example, the index card that particular patient is holding. Now, next up, we have the light adjustable lens, so the LAL for short. This is a lens that's really designed to give you precision and accuracy. So it's designed to give you one focal point. What's really great about the LAL is it's customizable. So we can actually adjust and tweak the prescription of that lens after we've done the surgery. And you're able to adjust it 3 times, and then there's 2 mandatory lock-ins. So a total of 5 treatments that are available there. And you can correct astigmatism with this lens, and it really offers fantastic quality vision. Now, the LEL technology is different than any other lens in that, again, it's adjustable. So let's say 2 weeks after surgery, we check your prescription and you're like, Doc, I kind of want a little bit more distance in one eye or a little bit more near. You have a residual refraction or prescription left over. We can actually dial that residual prescription into the lens without doing any additional surgery. And basically what it looks like, there's a microscope there that emits concentrated UV light, and that UV light actually changes the shape of the lens as it sits in the eye. And again, we can do that 3 adjustments to really fine tune it to exactly what you're looking for. And then we lock it in twice so that it no longer changes. This is really your highest chance of achieving 20/20 vision or better because we're able to make up for that residual prescription by basically adjusting that lens. And for patients who are really looking to get the highest precision out of cataract surgery, I typically recommend the light adjustable lens. And I also recommend it for anybody who has had any corneal surgery like LASIK or PRK in the past, because it gives us the ability to fine tune it. And a lot of times the measurements that we get for patients who've had LASIK and RK or PRK, they're a little bit less accurate. And being able to make up for that margin of error with the light adjustable lens really offers these patients the highest chance of getting to that 20/20 vision. Now the LAL profile is going to be, it's going to give you that distance vision. So it's going to be set for one focal point. And then for reading and intermediate vision, you'll need to throw a pair of cheaters on, and minimal glare and halos with the LAL. So these patients are typically some of the happiest patients because ultimately you're telling us what you're wanting and we're just dialing it in after the fact, after surgery. Now, who's the right candidate for the light adjustable lens? It's going to be somebody who's looking for the highest precision and the ability to adjust the IOL afterwards. You do have to wear UV protection for 4 to 6 weeks after surgery to prevent unintended UV light exposure from changing the shape of the lens. And I'll show you what that looks like here in just a moment. And the nice thing is, for patients who have mild ocular pathology, this is a really nice option if they're looking sort of to get the highest precision and highest accuracy out of their surgery. Now, these are the UV protective lenses that you're required to wear for those 4 to 6 weeks after surgery, just to make sure that lens doesn't shift. So you need to be willing to wear that UV protection afterwards. You need to be willing to come into the office for a few extra visits after the fact. So anywhere between 3 to 5 additional visits to make sure that we're able to fine tune that lens. And then lastly, you're really desiring the ability to test out or test drive your vision. So if you're looking to kind of see what it would look like and you want to kind of fine tune it, play around with it, give put one eye a little bit more distance, one eye a little bit more near, this is a fantastic option to really test drive that vision before you have to dial it in and lock it in. Now, next up, we have the pinhole intraocular lens. So this is a lens that's designed to give you a functional range of vision. It's implanted in one eye. So it's typically implanted in a monovision style where one eye is set for distance and one eye is set for near. And with the pinhole optic, it should give you a nice range of vision alongside the other eye that's typically set for distance. So I typically reserve this lens for patients who have irregular cornea. So if they've had prior history of RK or they have corneal scars or things of that sort that are really making the cornea irregular, this is a good option because it really helps to focus the light directly on the retina and focus the image directly on the retina to provide the best quality vision as well. Now, with the IC8, when it's implanted with monovision, you're going to have that nice full range of vision. There are some visual imperfections that can happen, some glare and halos, and some dimming effect that can sometimes be associated with the IC8. But overall, these patients tend to be very, very happy because they get the full range of vision. Now, one thing that I like to talk about too is monovision. You can do monovision with other lenses as well. So for patients who've had monovision with a contact lens, meaning one eye was set for distance and one eye was set for near, we can do that surgically through cataract surgery, where we do the same thing. We just implant different lens powers, and one eye is again set for distance and the other set for near. And that gives you a really nice blended vision that minimizes your need for glasses. So if you've tried monovision in the past, we can do it surgically through cataract surgery. Now, for comparison, here we have all the lenses kind of laid out. Multifocals and IC8s are going to give you that full range of vision. Just keep in mind you're going to have some glare and halos there. The extended depth of focus lenses are going to give you distance and intermediate, and then you throw a pair of cheaters on. Less glare and halos with the extended depth of field lenses. And then we have toric and light adjustable lens that's going to give you that one focal point with really fantastic vision. And then you'll have to wear reading glasses for up close work. And then lastly, we have the monofocal lens, which is going to give you good vision, but you'll have to wear glasses for the majority of the time for distance and for near. So next up, we have laser-assisted cataract surgery and aura. So when we do cataract surgery, we can either do it completely by hand manually, where we use traditional blades to make the incisions. We use a blade to make the opening of the cataract, and we break up the cataract manually by hand. In comparison, there's also an option to do laser-assisted surgery, where the laser adds a little bit of precision. It automates the more delicate parts of the surgery for us to really streamline the procedure and add a layer of safety as well. So what are the benefits and advantages of laser-assisted surgery? One is you get a precise capsulotomy. The capsulotomy is basically the opening of the cataract, which we would otherwise use a blade for. Typically is the most delicate part of the surgery, so automating that with a laser does add a little bit of a safety layer. There's a lens softening effect, meaning the laser actually breaks up the cataract for us into a bunch of little pieces, and that way we spend less time in the eye, we spend less ultrasound in the eye, so there's less risk of damage to the internal structures. The nice thing is it can be paired with any lens. So whether you choose the basic lens or you choose a multifocal lens, you can add laser. And if you have a low level of astigmatism, typically less than a diopter, I look at preferably less than a half a diopter, you can correct it with the laser as well. And when we do laser, we do it typically just prior to entering the operating room. So it's done just before your actual surgery takes place. We go to one room where the laser is, we do the laser portion, and then we wheel you into the operating room right after. So who's the right candidate for laser? If you have really dense or advanced cataracts, we typically recommend laser because it reduces the amount of ultrasound that we use in the eye, which then reduces the amount of swelling that you develop, the amount of inflammation. Now, if you have corneal disease like Fuchs dystrophy, That can also be addressed with the laser because it reduces, again, the amount of ultrasound ultimately that we're using. And if you're looking for the most advanced technology, if you're looking to kind of get the highest precision out of surgery, this is a really good option for you as well. And again, it can be paired with any lens that you choose. Now, is there a way to verify the lens one last time prior to implantation? Meaning, when we do measurements ahead of time to really determine what lens to put inside the eye, but is there a way to do it after we've removed the cataract and we're ready to implant the lens? Is there a way to verify that one more time? And fortunately, with the current technology, there really is. That's where aura or intraoperative aberrometry comes into place. And that's just a fancy way of saying we do one final measurement prior to implanting the lens. And this really helps fine tune the lens selection. So lenses come in different sizes, and somebody can be a size 7 and somebody can be a size 7.5. And we really don't have a perfect way of determining that. But using the aura, it allows us to really get one final measurement at the end, just prior to implantation, to really fine tune and dial in the appropriate lens. So this is a good option, again, for somebody who's looking to get the highest precision and highest technology from surgery. Now, when we looked at all the lenses in combination with the laser and in combination with aura, it's really a fantastic time to be a patient because the technology is just so incredible. And it gives you so many different options that you can kind of pursue, really just depending on your goals and what you're looking to get out of surgery. And when you come in for your consultation, you should expect to have a comprehensive exam, expect to be dilated. We do corneal maps and retinal scans. We have a thorough discussion of all of your options. And then together, we decide on a plan together moving forward on what's the best lens for your specific eye and your specific needs and goals. And with that, I'd like to thank everybody for attending, and I'm happy to take any questions. All right, Gabe, do you have any questions on your end that have come through?
No, we have a couple of raised hands. I think we have Tracy Strauss.
Okay.
For any raised hands, please feel free to write your questions in the chat and we'll address them.
Yeah.
And Gabriel, feel free to field those as they come. I think they're going to come on your end.
Okay. Yeah, we have our first one here. It says, do you ever implant the IC8 in both eyes?
So that's a great question. There are surgeons who have done it in both eyes. It would be considered off-label, though. So the FDA approval is to have it implanted in one eye, and then in the dominant eye, you would do a basic or toric lens. So for those patients, yeah, you can consider having it done in both eyes, but technically the FDA approval is one eye.
Thank you. Okay, Dr. Ahmad, we have our next question. Tracy asked or said, I heard that the more advanced cataract surgery might not last.
That's not correct. No. So once the cataract is removed and we implanted a new lens, that new lens is good for life. You can develop a little film behind the lens, which is very common. That's called a secondary cataract or a PCO. And if that develops, we just do a quick laser polishing that's covered by insurance to restore the vision.
Thank you. And then we have another question, Dr. Ahmad. Tracy asked, does the vision lessen over time?
Can we get a little bit more context, like before surgery, after surgery?
Okay, I'll wait for her response.
So if you have a cataract and it's there and you're not doing anything about it, it will progress with time. And typically, after you've had cataract surgery, as long as everything else in the eye is pristine and like you don't have any new retinal changes, any glaucoma, any significant dry eye, then the vision should not diminish over time
Okay. Yeah, she meant to put after the surgery, so I appreciate
afterwards. Yeah.
that. And then we have our next question. Lynn is asking this for a spouse. When they had their eyes done at Harvard, it says that no one told them that the lens had a squared edge, which would create excess glare. Um, what idiosyncrasies of this sort are there, and how do we learn of it?
So different lenses have different sort of edge designs. There are some lenses that are square edge that that can lead to some dysphotopsia or some visual phenomena. But the majority of lenses are designed specifically to minimize any sort of visual phenomena like that after the fact. So the newest technology lenses really are designed to minimize as much as possible.
Okay. And next question, it says, what if you have extreme dry eyes that is chronic and is being treated? Are you able to get the surgery for cataract?
That's a fantastic question. So I tend to be very cautious when I'm proceeding with a dry eye patient with cataract surgery. You really want to optimize that surface as much as you can so that you can get accurate measurements because the measurements really depend on the corneal surface. And in dry eye patients, that surface is typically very irregular, very irritated, and that can lead to inaccuracies in measurements. So that's one reason. Another reason is oftentimes after cataract surgery, patients tend to get a little bit more dry eye temporarily. And so we really want to make sure that we can optimize that surface as much as possible beforehand.
Okay. And then someone asked if you can be more specific as to the degree of limitation of physical activity.
Yeah, so because you have fresh incisions in the cornea, we want to make sure that they stay sealed. If you have significant strain or you're lifting heavy objects, that can potentially open up those incisions in that very small perioperative window. So 2 weeks, I always tell my patients, no heavy lifting, nothing over 10 pounds, no bending. So if you're going to bend at the hip, um, and then no straining. So try to avoid any excessive lifting, any coughing fits, sneezing fits as best you can, just to minimize any possible strain on those incisions.
Thank you, Dr. Ahmad.
And we typically do the eyes usually 1 or 2 weeks apart, and that 2 week period is per eye.
It looks like that is all.
Well, awesome. There's a QR code there in the bottom right-hand corner. If you're interested in getting a consultation, feel free to scan that. That'll take you directly to our Harvard Eye page where you can put in your information, and we'll be more than happy to see you in the office.
Yeah, I appreciate it, Dr. Ahmad. Thank you so much for the wonderful presentation. And thank you to all of our guests who attended this evening. Remember, if you do have any additional questions, please feel free to email marketing@harvardeye.com and we'll be able to answer any additional questions you may have. But other than that, we look forward and hope to see you at our next webinar event and have a great evening.
Thank you guys for attending. Hopefully that was informative. Have a good evening.
Thank you, Dr. Ahmad.
Take care. Bye-bye.